anyway, Kaitlyn's here. She's going to talk about rehab and really where that nursing perspective and treatment plan comes into play, because apparently you can't do it all and be there 24/7.
I try my best, but I cannot.
There's only so much time in the day. Ladies and gentlemen, without further ado, Kaitlyn Lozano. Oh, sorry. So
it's still this one?
It's this
Okay.
one, and then right and left.
Yeah.
Right will advance. And then you have a laser right above it.
Yep. Should I wait for Rebecca?
Go ahead and get started.
Okay.
Yeah.
Okay. So as Clayton mentioned, I'm a physical therapist here. I've been working here, came out fresh from college, and I've been here ever since. So it's pretty much all I know is this burn world. All right, so I've been doing these presentations a couple times now, but I just reordered and reformatted my whole thing, so if I'm not flowing exactly, that's why. All right.
Is it not advancing?
It's on.
I think I know why.
Is the thing not in the sound?
Yes, I plugged it to plug in my presentation. Sorry about that.
Here we go. Okay, so basically our rehabilitation goals, in the short term, which we can kind of categorize these short-term goals as what we're doing on the unit. So when that patient is in the ICU, the PICU. And then our long-term goals are more so once that patient transitions to outpatient. However, we do have patients that spend a shorter amount of time on the ICU, and so sometimes their short-term goals aren't completely met during that time, and those carry over into outpatient. And the opposite, where we have patients that spend a very long time on the ICU, and so then we kind of transition into some of our longer-term goals on the ICU. So basically for short-term goals, we're generally focusing on preserving the range of motion that they have. Typically when our patients come in with a burn injury, our initial evaluation, they've got all of their range of motion, they're perfectly functional. Typically our patients are independent right before this injury happens, and then the deficits kind of develop during this process of healing. So maybe initially they've got full range of motion, full strength, they can get up and walk to the bathroom, but then after ORs and periods of bed rest and immobilization, then they start to develop these issues that we then have to work to combat, that loss of range of motion, scar band contracture formation, and decreased strength, decreased muscle mass. So we're kind of working to preserve the range of motion, preserve their functional ability from the go. And then long-term goals are really focused on returning that patient back to their life and getting them back to, or as close to normal, as close to what they were, their pre-burn functional levels. Sometimes it's impossible to get them back to their pre-functional level because now they've had an amputation or multiple amputations, but we're always going to work to get them to maximize their independence for when they go back home and go back to their life. So our goals are going to be focused on range of motion, strength, mobility, their transfers, balance, gait, so walking, splinting and positioning, so working with the caregivers because our kids aren't always compliant with everything, so working with the caregivers to get that buy-in, and working up their tolerance to the positioning and splinting. Scar management, it's easy to think of that obviously in the outpatient setting, but really scar management is beginning the day they step on that PICU, because it's inevitable that they're going to have scars. And patient and caregiver education, so educating them and being realistic with what are our outcomes going to be? Like, what do we believe? We know that these scars are going to form and they're going to continue to hypertrophy, and you're going to get contractures, and so we need everyone to be aware that this is what's going to happen, this is why we're doing these things right now, and this is what we'll have to do in the future. And then ADL training, so their activities of daily living. So nursing involvement in rehabilitation, generally during our treatments on the PICU, assisting with the lines and tubes if a patient has a chest tube initially, or if they've got a Foley, or if they're connected. I know that lately we've been having them just with the saline locks, so they haven't been connected to lines as often, so that's really helpful as far as going in there. We never want to be the ones to pull out a line, so having y'all there to help us monitor that is great. And assisting in treatment, so ensuring that the splints are intact at all times, or at least as recommended by the therapist. So I know that we've been starting to do the reminders on the Citrix, so that's been helpful. And if you ever have any questions, absolutely just call your therapist and ask them. So monitoring the patient's position to make sure that they are in anti-deformity position, and we'll go through that just to refresh you, and that they're in a pressure relieving position, and to support our rehab goals. So one of the things with this is that sometimes for occupational therapy, that therapist might think it's appropriate for the patient to be working on feeding themselves. So, we really want to try to promote the goals at all times, So if you go in there and the patient's like, I want some juice, prompt them to, hold their own cup and kind of bring it to their mouth. And you might have to help them because obviously they are in therapy, so they're not doing it completely independently yet, but trying to support our rehab goals as best as possible. Because in the 24 hours of the day, we are only with that patient 3, maybe, between PT and OT. And y'all are there all the time, and obviously the caregiver's there all the time too. So our patients specifically, their healing is relative to the extent and the distribution of the burn injury. So the burn wounds are going to heal just like any other wound with scar formation. So the scars are fibrotic tissue that replaces the normal tissue. And if we kind of just leave these unmanaged, they can get very hypertrophic, and then that can cause contracture formation, scar banding, which ultimately can lead to decreased range of motion and impairing their function, amongst other things that it does. So the scar development actually can be influenced by a bunch of different things: infection, genetics. Some kids I've seen over the years, some kids just are more prone to scar hypertrophy, and I think that you can kind of see that in your regular daily life. Some people, they'll just fall down, skin their knee, and they end up with this big overgrown scar. And other people can have a road rash, and it heals really nicely, really nice and flat. So there's immunological factors. I've seen typically with reharvesting of the same donor site over and over again, that can lead to hypertrophy of that area as well. The age, the location, and the tension of the scar can also influence the way that scar develops. And so this scar maturation process, basically the scars are active and can be active for up to 2 years, and this is after the wound is closed. So the scar is only formed once that wound is fully closed. So if the patient stays open, say they come in January with their burn, and finally by March we're getting those wounds closed. Once those wounds closed, that's when this process starts of this scar maturation phase. And so this can be up to 2 years for some kids. Some kids, their scars mature after 1 year. It's just, we don't know, and so we always treat a patient as if it's going to be up to 2 years, because if we stop all of our scar management too soon, then they're at risk for more hypertrophy, and if those scars are still active, we just want to make sure that that patient is covered. So we always treat it as if it's up to 2 years. So the way that we assess scars, we use this Vancouver scar scale, and so this looks at the pigmentation of the scars, the vascularity, so when you're applying pressure, does it blanch, the pliability, and the height of the scars. Typically what I've seen with our patients is that once they heal, those scars really, when you first do this exam, the numbers will kind of be relatively low, and then usually 3 months in, they start to increase because those scars are getting really active now with their remodeling. And then after a period of time, it'll kind of start to calm down again. So for scar management, we're looking to do active and passive range of motion just to keep those scars, keep the tissues very mobile, sustained stretching to keep the tissues lengthened, static splinting, so that's just those thermoplastic splints that we put on just to maintain them in a good position. Scar massage, because typically when the scars are healing, those multiple layers of the skin kind of get adhered together. And especially over a muscle belly, you can see that skin will kind of get adhered down to the muscle. And whenever the patient flexes or extends their wrist, you see it move with it. So we want to do a lot of scar massage to make sure to keep those levels mobile. Heat, not always indicated, obviously because of the mechanism of injury for our kids. Sometimes that's they don't tolerate it, but oftentimes heat can help to soften those scars and allow the tissues to relax and lengthen. Pressure is one of our, I think, main focus, and we'll go into more detail about that. So with the pressure, we're using ACE wraps on the unit. This is our first line of pressure. We'll often transition to Tubigrip. We use Coban a lot on the hands, but we can also use it on the feet. Moving into interim and custom garments, you'll typically see those more in the outpatient, but we have had patients that if they're on the unit long enough, they'll get into that. UVEX face masks, so those are those clear face masks, and that's what we use to apply pressure to the face. And silicone, we have adhesive silicone patches that we can stick on, and we'll further discuss those. So like I said, the pressure dressings, that is beginning on the unit. So with standard wound dressings, your primary wound dressings, your poly, fine mesh, whatever you're using as an antibacterial for that wound. And then secondary would be spiraling the Kerlix on, and then doing either a figure of 8 wrap or using Surgeonette. And then when you're doing, as Mr. Jean mentioned, when you're doing soaks, typically you'll put a layer of fine mesh there just to prevent the Kerlix from sticking to the wounds, bulky Kerlix, and the figure of 8 wrap over top of that. So the pressure actually provides a mechanical support to initiate that healing of the wound. It can help to reduce tissue swelling and promote softening of the burn scar as it's forming. So you always want to make sure that you're beginning at the most distal point and move proximally. So patients, when you're wrapping the arm, obviously your most distal point, you're going to start the ACE wrap at the hand, but you can't forget about those fingers. So even if the fingers aren't necessarily involved, our patients early on are still, they still have the tendency to get very swollen because they're not managing their edema very well. So if you kind of started at the palm and go up, they can end up with really swollen fingers. So we always want to put the Kerlix and Tubigrip sleeves on the fingers just to keep that pressure gradient distal to proximal. And same thing with the foot, the toes as well. So, and you're always wanting to wrap in this anti-deformity position. So it's a lot easier to splint a patient in our anti-deformity position when they're already maintained in that with the pressure dressing. So it's not gonna hold it completely in that position, but ultimately that's the position we want them to rest in. So we need to wrap them in it. So this is the figure of 8, as we're all familiar with. Like I said, starting with the Kerlix and the Surgeonette for the fingers. And then applying your spiral Kerlix, nice and even, and then doing the figure of 8, that crisscross pattern up. So residual limb dressings are a little bit more difficult. And those, it's really important that we do those correctly. So I don't know if this is gonna, This is a video. Let me figure out how to do it. Well, I don't know how to start the video, but it was a video. So basically with a residual limb dressing, for example, for a below the knee amputation, you want to start just lateral to the tibial tuberosity. So it's that little bump that's right under your kneecap. You're going to start lateral to it, and you go down to cover the limb, and then you just need to make sure that you are covering everything. Your ACE is going to be covering 50% of itself to make sure that the pressure is consistent. Typically for a lot of times we have our patients on the unit that they go for the amputation, but it's not closed completely. In that case, I personally like to double wrap that limb, just because everything is not closed. We want to make sure that it stays together. So residual limb wrapping, this can be your basis for shaping the limb, so it's important that it's done correctly. And then once you cover the distal end, you want to make sure there's no wrinkles or dog ears. That's kind of when you make a turn with the ACE and it lifts up. So just trying to do that as smoothly as possible. And then you just figure of 8 wrap up the top of it. So moving on to Tubigrip. This is that elasticized tubular bandage. This provides pressure to the wounds, and it's for edema management. So we typically will move into this when the patient's got just very minor open wounds remaining. It helps the patient to move a little bit more freely, and kind of decrease some of the bulk that the Curlex and ACE was giving. So you can cover up the smaller open wounds with a little fine mesh and the adhesive cover roll. These can be reusable if the patient is not draining, if their wounds aren't significant. You can reuse these a few times just to save material, hand washing with soap and water and just letting to dry. But if the patient's still bleeding out or draining, you definitely just want to throw those out and get a new pair. Sizing is very important, and I believe there's still I made little size charts a while ago. And I put them into the supplies room on 2 East. Sizing is really important because if it's too loose, it's not going to be applying the compression that the patient needs to those wounds. But also if it's too tight, that can cause more issues, can cause swelling and just too much pressure. Because they have the elastic string throughout it, sometimes you'll pull it off, and if you can see those elastic strings, it may have been too tight. So Coban, so this is that self-adherent tape. We typically will don this over primary wound dressing, so just up to that fine mesh layer. You never want to put this over Curlex, just over fine mesh. And that's just so that it doesn't stick to the wounds and cause more further breakdown. So you don't want to put this on if the patient's hands or feet are excessively open, and that you just kind of want to stick to your primary wound dressings. You want to don this without stretch. So sometimes that seems not appropriate, but when you put the stretch on and then the patient sits with that for hours and hours, it's going to cause pressure, and it's been as significant as patients losing digits because of it, because it gets really tight. When I was doing this presentation before, I'd actually brought in like strips so that you can pull it and stretch it and put it on your finger and see how that feels. So whenever you put this on a patient, you need to make sure that there is zero stretch. You're basically just laying it on. And it's self-adherent, so it sticks to itself, so you don't have to worry about it falling off. Just kind of press down on it at the seams to make sure that it doesn't come undone. And you're always donning this in a glove pattern, so to make it look like that. And always distal to proximal, obviously. You want to get in there doing your web spaces and make sure that nothing is left uncovered. So even if you have a little area here between the 2 pieces of tape and oh, it's a tiny little area, well, you have this pressure over everything on your hand, and so if you even have a little spot that's open, that can get very swollen because the fluid's going to want to pocket wherever it can. So you want to make sure that everything is covered, and so you just kind of, after you make the glove, you just go and patch up the pieces that are left open. So this is really important. We often do this with patients that have had digits amputated, because it's kind of our first opportunity to start shaping the hand and shaping the digits after the amputations. These are always disposable after use. Once you take it off, just trash it. So compression garments. So Shriners, we provide 2 pairs of compression garments to rotate. So the patients will be wearing these 23/7. So they're basically only taking them off for a bath, and then after their bath, they put the clean ones on. So garments are only ever hand washed. If they go into the machine, it kind of breaks down the stitching, and then it doesn't provide the compression that it needs and as consistently.
Hey, heard the video went down? Jeannie said?
Oh, well, I couldn't. Oh, wait, my video?
Yeah, we have them on webcam, so sorry to interrupt.
Video. So like I said, we're starting at the tibial, just lateral to the tibial tuberosity. And this is a patient that was in outpatient, so, you know, it wasn't, the limb wasn't significantly open. So we're retracing our steps, covering those, covering the ACE 50%. And like I said, when it is significantly open, still in that real acute phase of this, you want to cover the distal limb twice. And then you're just going to continue up the leg with your figure of 8. And so it's important to mention with this, sizing of your ACE is very important. If you have a little 3-year-old, you're not going to start a residual limb wrap with a 4-inch ACE because you're going to end up overlapping your ACE too much to cover that residual limb. So you want to make sure that you're choosing the appropriately sized ACE. Similarly, if it's an older patient like this patient here, and you're starting with a 2-inch ACE, you're going to end up with a lot of ACE on that. And the compression that you're applying can be very inconsistent. So you want to make sure that you're using the correct size ACE. Okay, so going back to the compression garments, always washed, hand washed and laid to dry with soap and water. Like I said, the machines will kind of break down the stitching, and then the garments don't last as long because you can get holes in the seams and doesn't apply the pressure. So you never want to cut the garments. Sometimes on the unit, if a patient still has a pulse ox, we'll put a little hole in the sock and kind of extend it. I would just recommend to talk with the therapist that put the garments on before you go ahead and cut anything, just to make sure that that's not a custom garment, because the custom garments are very expensive. We measure we measure the patients pretty much every inch of their body, and then we send out for the custom garments. And sometimes the materials that we order can look similar to the interim garments. The interim garments are just a standard sizing. We keep them in stock, so those are a lot easier to replace. So just communicate with your therapist, like, hey, I need to put a pulse ox on this kid, so what can we do? Can we take the sock off, or can we put a little hole? So just to make sure to communicate with your therapist. As I had mentioned before, the use of silicone patches. So we have these silicone patches, and basically the silicone kind of, when it's placed on a scar, it can help to soften the scar and promote flattening, because you're increasing the pressure to that area, and it's also able to get a greater contour. So we'll use those for more irregular areas, or areas that maybe the scarring is a little bit more significant, a little bit more hypertrophic. We typically will replace the garments every 3 to 6 months, depending on the patient. Obviously, like little kids, 2 years old, they grow so rapidly, we might have to replace them every 3 months, maybe less. Our older patients, that aren't growing as rapidly, we can kind of get away with every 6 months, but some kids just are a little bit more rough and tumble, and they wear through their garments quicker. So we just assess every time that they come back, and we assess their needs. So I kind of discussed a little bit of this already, the difference between the interim garments and the custom garments. The interim garments we'll typically begin with because it's a softer stitch, it's a lighter grade of compression. So this helps to acclimate the patient to the pressure. Ultimately, we'll be wanting to get them into the custom garments because it's a medical grade compression, it's a tighter stitch. However, some scars don't require that level of compression. Some for our more superficial scars, we can get away with just doing the interim garments. So it's kind of up to the discretion of the therapist on what that patient needs. But those are the differences. So this is one very, very important thing. You guys may have seen this around the unit. So for the compression garments, this is correct. It looks incorrect because the seams are on the outside, the tag's sticking out, but this is the correct way that we want to be donning these garments. And the reason for that is because this seam is pretty thick. So if you put it on like this one that is incorrect, this is technically inside out, that seam's going to be pushing into their skin. And for our kids that their skin's still very fragile, they're very susceptible to breakdown. So when you have this very large seam on a very tight compression garment, it can cause pressure. And once you remove that sleeve, you'll see like a line down the patient's skin, and we don't want to cause any more open wounds. So it's really important that we make sure the seams are always on the outside, tags sticking out, you're good to go. So what is the whole purpose of this scar compression? To be honest, I really didn't understand it when I first worked here. I just knew you got a burn, you put compression on it, that's what I was told. So really, when I started doing some research, I found out that the whole point of this compression is that when you apply compression to an active scar, remember, the scar is only in this remodeling phase for up to 2 years. So we've got up to 2 years to really maximize our potential with these scars. Beyond that, it's a non-active scar, and it kind of is what it is. As the patient further grows and gains weight, the scars might stretch out and they can kind of change because of that, but the scars are really done forming at that time. So in this active phase, once you apply pressure to a scar, and you see that when you're applying that pressure, the skin kind of blanches, so it goes white, that's it's showing that there's less oxygen making it to that scar. And the oxygen is really what's bringing all the nutrients to build that scar up. So when we apply the compression, kind of impedes the collagen production, and it establishes this balance of scar breakdown and scar buildup, so that those scars are not going to further hypertrophy, and they're kind of gonna flatten out. So positioning. We're always positioning to counteract those contractile forces. With hypertrophic scars, they tend to get very tight, and it'll kind of pull these patients into a contracted position. So we're always trying to position them to oppose those forces. We're always positioning to prevent pressure, so heels always offloaded. If the patient's on their side, let's make sure that they're not resting straight on their greater troch, so to avoid pressure. We need to promote wound healing. So when a patient comes back from the OR with a bunch of grafts on, we need to position them so that they're not going to be putting too much pressure on on the grafts, or moving in a way that's going to cause shear. So we're promoting wound healing. We're supporting the joints to maintain the proper alignment. A lot of our kids with significant hand burns and injuries, they get pulled into contractures, and typically we'll end up with like hyperextension of these MCPs, and that can cause poor malalignment of the joints there and kind of dislocate them, and we always want to keep them in this anti-deformity position to maintain tissue extensibility, like I said, to protect the grafting, and for edema reduction. So we're always elevating those hands so they don't get swollen if they're sitting in a dependent position. So ways that we do this, we use our thermoplastic splinting. We do serial casting. We don't often do it on the unit, but when it's indicated, we do it. Foam troughs. Sometimes we'll do foam mattresses if a patient needs like a neck extension mattress to really keep those tissues lengthened over the neck. Pillows, Z-flows, and ultimately we can use surgical pins to really promote the positioning of the digits. And so we're always trying to avoid this. So this is a result of a patient that sat in their position of comfort, which is obviously all kind of curled up. So these are the significant the contractile forces that we're trying to counteract. So ways that we can do this is promoting range of motion, and they're in the bed. So turning their head side to side, turning the bed. If a patient wants to always be looking at mom because mom sits on the left side, let's have mom sit on the right side. So you can turn the bed so that they can watch TV and have to turn either way. Also that we can avoid this position of comfort. So the anti-deformity position that we're hoping for is keeping the neck in about 15 degrees of extension. This is very, very important if your patient has neck and anterior chest burns, because they'll end up resting in this position and then they'll end up getting contracted in that position. And it's very difficult to undo after the fact. So always trying to promote neck extension. You can do this by putting a shoulder roll in between the shoulder blades just to kind of lift up the chest, cause some expansion there. We always want to elevate the arms. That's for edema reduction, but it's also to keep the axillas in a good position. Keeping them out helps to not keep them contracted to their sides. So the elbows always extended so that the patient doesn't end up contracted in flexion. The hand positioning we often will just do with the thermoplastic splints. That's kind of the best way to really focus on the hands in the exact position that we want them. Hips always extended. I am personally a fan of reverse Trendelenburg, so keeping those hips completely extended in the bed. Obviously we need to elevate the head, so we elevate the whole head of bed. We elevate the head by putting that bed in reverse Trendelenburg, so inclining. And obviously there's issues with that the patient slides, but especially when a patient has anterior hip burns, it's really important to keep those hips extended. Knees in full extension, and ankles always in neutral, and with the heels offloaded, obviously. So we do that with AFOs. If a patient is prone, we use the footboard. There's a few different ways that we will work to maintain that neutral ankle position, but that is one of the most important things, because if a patient ends up contracted at the ankles, they're going to have a real hard time walking. Getting out of bed is going to be very painful, so their basic mobility is going to be impaired just because of an ankle contracture. So we always try to focus on keeping the range as best we can. So splinting, as I mentioned, this is that thermoplastic material that we use. You'll see it in white, black, red, blue. This helps to maintain the joint position, maintain that anti-deformity position. We typically will don them on the unit in ACE wraps, just because a patient, they typically have more open wounds, and so if we use foam strapping, yeah, it's easier to don and doff, but those foam straps can get saturated with drainage, and that's just an infection risk. So we typically will do the ACE wraps just so that they're disposable and it's not staying on the patient. The thermoplastic splint material, we can always wipe those down. Typically when the therapists come in every day post-op to assess the splints, we'll be wiping them down and cleaning them as to not hold infection to the limb. So these are to be worn at all times. Even taking them off for an hour just because the patient says, it hurts, it's uncomfortable. It's uncomfortable to wear this, but it's ultimately going to be more uncomfortable to be walking on a contracture. So it's really important to have those on at all times. Even if a patient is complaining of significant pain, my suggestion is to notify your therapist to say they're complaining about it, but I wouldn't just go ahead and take it off immediately. I would consult the therapist about it so that we can modify it, because maybe it is pushing and causing pressure, and so obviously we don't want that. We'll modify it so that it is comfortable, but the patients do have to wear them at all times. Serial casting, like I mentioned, we don't typically do it on the unit, but basically that's a way to apply a circumferential pressure, maintaining a range of motion. That helps to really allow the soft tissues to relax and lengthen. We do it a lot for patients that are already contracted, and so we'll apply the cast, and while it's wet, we stretch them into the position we need them to be in, and then once it dries and hardens, they stay in that position maybe 2 to 3 days, and then we take it down and check the range of motion again. So it's kind of a way to apply a gentle stretch and a prolonged stretch to get more range of motion. So these are just a couple of the different splints that we have. These, you typically won't see them on the unit, more so in outpatient for stretching the mouth, because you can see the skin gets obviously tight on the outside, but the inside of the mouth gets tight as well. So it's really important to promote the patient to be doing mouth exercises and opening and closing, especially if they have facial involvement. This one over here is for, it's a hard neck collar to block torticollis. So a patient that maybe sat in bed all the time like this, and now they're contracted in that position. So we're lifting them up to neutral, lifting their chin up into a little bit of extension to get them in the position that we want them to be in. This is obviously our standard resting hand splint. We've got Coban on there and some Tubigrip. And really this is to counteract this position. Like I said, the joints can sometimes get pulled out of alignment and dislocation, so we really want to prevent that. Some other ones that are typical for outpatient: a soft neck collar to maintain the contour of the neck and the range of motion, axilla pads to apply some pressure to the axilla, and this also helps to promote chest expansion. This patient here obviously has an interim face mask on to apply pressure to the face, and a hard neck collar. This little guy's kind of got everything here. This is the axillary pads. He's got an anterior hip spica. So basically, I've had to do this a couple times for our little kids that they move around so much in bed. So we kind of elevate the head of the bed, elevate the foot of the bed, and they sit in this V position, and they get significant contractures at their anterior hips. And so when we finally get them up walking, they're hunched over like an old man. So we end up having to lay them flat as best we can and make this splint on them. They obviously can't do much in that splint, so they end up only wearing it at night or when they're resting in bed, but that's really important to maintain those hips in extension for your standing posture and your walking. And then this one here is for an airplane splint for an axillary contracture. So when the patient's getting tight, you want to really keep that arm up. And so sometimes we have to use this thermoplastic splinting. Oftentimes we'll use a foam block just because it's a little bit more comfortable if the patient has open wounds on their arm or on their trunk. We don't want to be putting the thermoplastic material, so the foam block can be a little bit more comfortable in that case, but it's the same function. So we're going to review, I know we did throughout this presentation, but we're going to review what happens if we don't do proper positioning and splinting techniques. So the risks of noncompliance are obviously contracture formation. I think I've said that enough, which can cause impaired function, decreased independence, increased length of stay, because oftentimes our patients come off the unit, and if they've got a contracture, once their wounds heal a little bit more, they're going to be going back for reconstructive surgery and neck releases and axillary releases to release the contractures that have already formed. So that increases their length of stay. Obviously, there's more cost to it, and the increased reconstructive needs for the future. So sometimes you can kind of tell there's obviously a reason that this patient maybe got contracted in the first place. Maybe they were non-compliant with their splints, or they didn't want to sit in the position, so this is why they ended up contracted. So you can kind of see that sometimes patients will end up with the same contracture on, and time after time they get a release, and they have a couple releases and they always end up contracted. It's kind of because the patient's sitting in their position and they're not doing their splinting. So more needs for the future. So this is our first example, and we can kind of review the deficits that this patient has. Obviously a significant neck contracture, so I'm sure this little one kind of just sat in bed all day, looks like the shoulders are pulled very forward, that probably don't have great mouth closure, so eating, oral function is probably impaired. Obviously their shoulder range of motion looks like that's probably limited. This can cause nerve and vessel entrapment. So some of the things that we could have done early on to prevent this, the use of a neck collar to maintain that range of motion, positioning with the neck in extension, positioning with a shoulder roll to keep that chest expanded, positioning with the arms up above 90 degrees. What else do I have here? Some active range of motion, stretching, bedside, doing scar massage to keep those scars from not getting so hypertrophic, and garments as well. So example 2, these are different patients, different pictures, but kind of the same idea with both. You obviously have very significant impairment of hand function here, shoulder function, elbow range of motion, lots of issues going on. You end up with this kind of webbing. Basically, when the skin heals, it's going to heal in the easiest way possible, in the shortest pathway possible. So if the arm's sitting like this, it's just going to heal straight across. So that's why it's important to always keep everything in this anti-deformity position, this more lengthened position. So what could we have done early on? Obviously an elbow conformer, resting hand splints, positioning the arms up in this plane of scaption, and then your range of motion, stretching, scar massage, garments. Example 3. So moving on to the lower extremities, we oftentimes end up with patients that have significant scarring in their popliteal fossa. That can cause scar banding there, which will decrease their range of motion to achieve terminal knee extension, which is very necessary for ambulating and using stairs, that sort of thing. Obviously this picture here with the ankles severely contracted into plantar flexion. You can see this patient is basically weight bearing through that 5th ray, that 5th MTP. So we're probably going to have some bony abnormalities there. You can see some breakdown right here, at least on my screen I can, up here. So early on, we could have used AFOs or the MP boots or a footboard, anything to keep those ankles in neutral position. Early mobility, early weight bearing, so that's really the best way to stretch these kids out, is to have them actually standing and up in those positions of function. And obviously scar management. So example 4, significant hand deformity. This thumb is kind of just adhered to the wrist. I'm sure that causes a lot of pain. This one here obviously has a really impaired hand function. So early on, we could have done some wrist cock-up splints to keep that wrist extended, to have avoided this and this. Hand exercises, so promoting those patients to use their hands, picking up fries to eat, and as much as they can using their own hands. So that kind of goes back to what I'm saying about promoting the rehab goals. And when you have a patient in the room, promoting them to do as much as they possibly can on their own for their self-care. If you have to do oral hygiene, try to see if they can hold the toothbrush, you know. Trying to promote them to be as independent as possible to prevent this impaired independence. This is our last example. This patient here, this appears to me that they've already had a neck release in the past. But they obviously still don't have great contour of their neck, not a lot of range of motion here. You can see this neck is positioned very forward. I doubt that they have very good mouth closure, so oral function. And if this picture went up a little bit higher, I'm sure you could see some contracting under the eyelid. So what we could have done early on, obviously having them in a neck collar, positioned in extension, range of motion, stretching, having them move that neck and head while they're in bed, you know, either way of having it functional, like talking to mom on this side, or like I said, turning the bed to watch TV, so that that patient's getting movement and they're not just sitting in the same position every day. Scar massage and a face mask. So ways to increase compliance, having caregiver buy-in, obviously that's the most important. A lot of the things that we do can cause pain or discomfort, you know, the splints and putting them in these positions, and they hate being in these positions, but educating the parents, the caregivers, on why this is so important right now, and you know what we're preventing basically, so that they have buy-in as well. I often try to have the caregiver involved as much as I can, so early on teaching them how to put splints on or how to check for positioning, kind of give the caregiver a role, and if they feel involved in this case, they're more apt to buy into it. And then, you know, for patients, giving them a reward system. I've gone as far as making sticker charts for wearing splints and doing their exercise programs. And then motivating the patients. We used to in the past do painting on the face mask, so they're more inclined to wear a face mask if it looks like Iron Man or Spider-Man. And then customizing their splints the way that they want. We try as much as we can to say, what color splint would you like? And we obviously only have like 3 different colors, but it's helpful for if the patient gets, you know, to choose a little bit of their plan of care. So that we do have the garments that you can get those in multiple colors and get little patches on them. So I think that that helps if they feel like they have a choice in it. Or anything that you guys can think of to have this help increase compliance is great. So that's all I've got today. Does anyone have any questions? All right, well, you know where to find me if you do.